Welcome back to the Trauma Anesthesiology Society podcast. It's probably the best podcast you're going to find that discuss trauma and anesthesia here in the U.S. It's hosted by our partners at Doc Matters. I'm Josh Sappenfield. I'm one of the co-chairs of the Educational Committee for the Trauma Anesthesia Society, and I'm from the University of Florida. I'm here again with Kevin Blaine, who is also a member of the Education Committee, and he's coming from Oregon Health and Science University. Our topic today is spine trauma, and joining us is Raj Nathwani and Arwan Dal from the University of Washington Harborview Medical Center. Welcome, gentlemen.
Let's start with a brief introduction to this topic. Dr. Doggle, what can you tell us about the epidemiology of spine trauma, and what are the specific anesthetic challenges that it poses?
Hi, Kevin. So we had, my training back in Nottingham, UK, as I was finishing there, that I was put to spine rooms a lot. So towards the end of my residency training, and then ended up moving to Seattle to one of the top trauma center in the US, in Harborview Medical Center, where I took the responsibility to look after spine population and anesthesia point of view. And with that, I have been focusing in the spine-related diseases and including trauma. And I have met with many individuals who had the unfortunate incident of receiving such an injury and changing their lives completely. Similar to that, there's probably about 330 million people currently lives in the US, according to recent consensus, with a spinal cord injury. There's about 18,000 new cases occur every year. And these are mostly middle-aged adults, like 43 years of age. Used to be much younger generation used to receive a spinal cord injury, but now we are moving towards the higher mean age group, and mostly males. About 80% of them are male patients. So this is roughly what the epidemiology, I think, currently in the US.
I mean, that's a really sobering thought. Thank you for sharing that. I know we do a lot of spine precautions, and they're used almost in all trauma at our hospital, but also where I trained before I came here. Longboards, C-collars, and other immobilization devices. They definitely add a lot of challenges to providing anesthetic care. How useful are they in protecting the unstable spine from further injury?
Thanks, Kevin. Yeah, so I think, spinal immobilization has kind of become the norm, and as ATLS has spread around the world, and with all airway goes C-spine immobilization, and we've all been taught it. And typically this involves a hard spinal board, a neck collar, lateral supports and straps to minimize the risk of unstable spinal columns kind of getting worse. And that's what we're all worried about, is that uninjured patient suddenly getting a devastating change in their condition because they've had a bit of neck movement. The problem is that there's not a huge amount of evidence behind all of this. There was a great review in the Scandinavian Journal of Trauma, Resus and Emergency Medicine in 2019, and really the evidence behind all of these bits, the spinal board, the neck collar, the lateral supports, the straps, is very, very low. And the other problem is, as you've just alluded to, is that they are problematic. So they make anesthetizing the patient difficult, but also the patient runs the risks of problems such as tissue ischemia, pressure ulcers if they're left on the spinal board for a long period of time, decreased lung volumes, aspirations, raised intracranial pressure, patient discomfort. So there are definitely side effects to spinal immobilization. And so there was a recent kind of consensus statement in the US in the Pre-Hospital Emergency Care Journal, which kind of said that maybe we should move away from the term spinal immobilization and talk about spinal motion restriction. And therefore, the borders of these terms are very much merged, but really to try and move away from just keeping everything rigid to just minimizing the unwanted movement to the potentially injured spine. And this could be done in a whole host of different ways, apart from our rigid spinal board and blocks and straps. And they suggested maybe a scoop stretcher or a vacuum mattress, and an ambulance cot could also be used. And I know in the UK and Australia, where I've also practiced, the use of vacuum splints from the pre-hospital arena all the way through the hospital setting to the operating room or to ICU is now very common, which means that actually patients are a lot more comfortable. It's easier to move these patients. There's a good amount of insulation provided by the vacuum mattress, and you don't have to have all the rigid parts in place. Now, I'm not saying that we should just do away with immobilization, but just to be aware that there are side effects of spinal immobilization, and it can be done in different ways. And the other part of it is that when someone has a collar on or they're strapped down, it does notify to all the other caregivers that there's a risk of spinal injury here. And maybe that's the real benefit of this, is that it does say to everybody that you've got to be ultra careful with these patients because we haven't cleared the spine. And that means that all team members, nursing staff, auxiliary staff, physicians, residents, everybody needs to know how to correctly manage these patients, because obviously mismanaging a potential injury can have absolutely disastrous consequences. So we need to know how to correctly position the patient, make sure they're comfortable, make sure we all know how to do a log roll, how to communicate when we're doing log rolls to minimize all risk. The other thing that I would say is that when we get to the airway management of these patients, really at that point, kind of taking off at least the anterior part of C-spine collars is important, and really then the patient should be managed with manual inline stabilization rather than leaving the collar on, because it becomes very difficult to open the mouth with collars on. If there are any difficulties with intubation, then having a C-spine collar on can be very, very difficult. And then the final thing that I would just like to highlight is that when we talk about spinal immobilization, then really we're talking about whole spine restriction or whole spine immobilization, not just the cervical spine. So because obviously, whilst the cervical spine is involved in 50% of spinal cord injury, 37% is thoracic and 11% is lumbar. So the rest of the spine also has to be borne in mind. There's always the risk of having non-contiguous injury. So we just don't want to be missing those as well. So it's important that we keep that in mind as well.
That's interesting. It sort of reminds me of the discussion we've had about cricoid pressure during RSIs and trauma, as to whether or not that's actually helpful, even though it's dogma. Yeah, I wonder what research in the future is going to show about spine motion restrictions and whether we should continue doing them.
Yeah, I mean, I think this is an area that is slowly evolving, and new technologies are slowly evolving. I should say that for people that are still doing cricoid pressure and there's a risk of C-spine injury, then really that is an area that really needs to be very carefully managed, and ideally should be a bimanual technique for cricoid pressure. And if you imagine having bimanual cricoid and having manual inline stabilization, you can see how difficult and how many people are going to be trying to work around the head and neck. So it is something to be ultra careful about.
Sure.
I just wanted to sort of add an anecdote maybe to this discussion in terms of stabilization. So I remember receiving a patient from outside hospital from a long distance. I think it was a patient from Alaska coming to Washington State. And patient was a spine injury, ankylosing spondylitis patient. So as you know, they are sloping forward and neck down, and had a ground level fall, come to hospital, all intact, with C5, 6, I think, fracture. And we did nice sort of stabilization, and patient was taken to the imaging afterwards, and where I guess the team left their guard to get this patient position in the MRI scan to be imaged. And as the MRI scanner, as you know, a very tight space. I remember a patient getting into a cardiac arrest and receiving a CPR because a loss of alignment in the cord and a spinal column. So it is what I want to emphasize here, that it is a high intensity and requires careful orchestration of the control of the spinal integrity whenever we approach this patient, so that we cannot take our eyes away from the patient and make sure that we don't further damage their spinal cord.
Great. The ABA loves to ask test questions about steroids for traumatic spine injury, and usually I feel like the correct answer is probably that you shouldn't give them. Are steroids harmful? Is there anybody that benefits from steroids after an injury?
Steroid question to me is still controversial. As you know, Congress of American Neurosurgeons and also ANA sort of published the 2013 guidelines. They are the latest guidelines for spinal cord injury. In that document, related to steroids and methylprednisolone use was not being recommended. So with that, I think there was a groundswell of reduction in use of steroids in spinal cord injured patients. But I also know that following the recommendations, there has been a lot of arguments about specific group of patients should still deserve to have steroids. If you ask us about our own practice, we don't generally use steroids, except when the surgeon feels that there will be potential benefit on a patient that there is no other option left. And, gaining one level of motor score is a huge improvement from someone who can lift their shoulders to get themselves into a wheelchair to not being able to move at all, is a significant improvement in the quality of life they will lead. Makes certain individuals, like young, healthy, no comorbidity patients, potentially candidate for steroid use. So we are currently doing that, and after discussion with the patient, family, and the surgical team and anesthesia team, and come up with possible offering of steroid use in these populations.
Interesting. So it's sort of a last resort.
It is indeed.
So another issue that comes up a lot during spine trauma is blood pressure targets. I know for the Brain Trauma Foundation for Traumatic Brain Injury, it's only like a level 3 recommendation. Are there or should there be blood pressure goals for spines?
I think that's a great question, because bringing up the parallel of traumatic brain injury with spinal cord injury, there are lots of similarities, and obviously, once again, neurons are at risk. And so what we can say definitively is that poor perfusion and hypotension to the spinal cord when it has been injured is bad, because there's going to be a penumbra of tissue that is then going to die. The question of blood pressure goals, once again, has poor evidence, but the American Association of Neurosurgeons and the Congress of Neurosurgeons have recommended, once again, a level 3 or 2B recommendation, a MAP of 85 to 90 for up to 7 days. Now, this is based on 2 prospective studies from the 1990s. So there are definitely problems, because obviously trauma management has moved on a little bit from the 90s. The question of 7 days comes about from the theory that swelling of those neurons becomes maximal around day 5. And so the study that was done by Vail et al. In the 90s continued the blood pressure targets for 7 days. But overall, the evidence is very weak. And so we now end up decompressing spines much sooner. And so whether continuing these MAP targets for so long is of benefit is hard to know. There is the MAPS study, which is currently recruiting, and they're looking at whether a MAP of 65 versus 85 has any detriment or not. What I would say is that really probably what we should be looking at is, in the same way as we look at cerebral perfusion pressure, we should probably be looking at spinal cord perfusion pressure. And so it's not just MAP that is important, but also the CSF pressure, or the CVP, that affects perfusion of the spinal cord. And maybe if the spine is being acutely decompressed with earlier surgery, then the requirement to maintain these MAP targets is that little bit less. I know from our own practice here, once the surgery has been undertaken and we've had decompression and stabilization of the spine, then we generally don't continue with these MAP targets. The only time we do continue for maybe 1 or 2 days after the operation is if there has been signal change during the operation when we're neuromonitoring the patient, and then there might be some benefit. In terms of which inotrope or pressor agent people are using, so traditionally this was dopamine or phenylephrine, and really most of us have moved on to using norepi for that process. Obviously, if it's a very high spinal cord injury, then there is the risk of bradycardia being more of an issue, especially if the injury pattern is above the T6 level, and then having some kind of inotropy would be of benefit. The final thing to mention is that obviously spinal cord injury is often part of major trauma. 2 to 5% of major trauma patients have some kind of spinal cord injury. And if we start augmenting pressures in patients that have other reasons to be bleeding, then there is a risk that the bleeding is made worse. So this is just something that should be borne in mind. And finally, any hypotensive patient in trauma, we need to rule out all the other causes of hypotension, especially hypovolemia, before we presume it to be a high spinal cord injury.
Interesting. On that topic then of sort of comparing spine trauma to brain trauma, brain injury, I'm wondering a bit about osmotic diuretics. Should we be trying to improve the spinal perfusion pressure with mannitol or hypertonic saline, like we sometimes do for TBI?
Kevin, I think there are some papers coming out regarding that. There are animal studies using mannitol to improve perfusion, as you mentioned, due to reduction in the IC spinal cord pressure. These measures generally require measurement, so monitoring. And unfortunately, we are not routinely doing spinal cord perfusion pressure monitoring just yet, or intrathecal pressure monitoring, but there are many trials going on in the United States looking into the area. Again, I believe there will be a space for that until the decompression is done, and maybe even afterwards for its neuroprotective effect suggested from osmotic diuretics. But at the moment, we are not in use of these agents to help us to manage spinal cord injury.
Going along the same lines, I know in the past there's been a lot of discussion about hypothermia possibly providing a neuroprotective effect. I've heard lots of various things. Where does the evidence sit for cooling or preventing rewarming in patients who are hypothermic?
So the evidence, in theory, it is not bad. So if we look at stem cell work and cellular work, then obviously keeping injured neurons cool can potentially minimize the further secondary neuronal injury. The problem is that that really doesn't translate into full clinical practice. And I suspect that's because therapeutic hypothermia has lots and lots of side effects. Firstly, if the patient is a polytrauma patient, then we all know that hypothermia induces coagulopathy and can make the acidosis worse. But also in itself, most of these patients are going to need long-term care. And so the hypothermia also induces poor wound healing, increases the risk of sepsis on ICU. So there are lots of issues when we try and translate cellular benefit to clinical practice with hypothermia. I mean, the thing that is being looked at is whether localized spinal cooling can be of benefit, and that's being actively investigated as we speak.
So Raj mentioned about the stem cell therapy. Again, I don't think we are in a space to use stem cell therapy in a routine basis, but there has been about 37 trials being published so far in stem cell research. And in Miami, you guys are doing a lot of work regarding both stem cell and hypothermia trials. And we are really eager to find out if there's anything come up with that trials. But this is an area I think is very interesting, and we are looking for further news and development in this space.
Yeah, thanks. It's really kind of an interesting evolving field. This has been a really great conversation. To summarize our discussion for today, what do you think are the key takeaways from managing traumatic spine injury in the operating room?
So I think from me, the three key things is that spinal immobilization or spinal motion restriction is a team game, and we all need to be on board with how to manage and adequately move these patients in a safe manner, whether that is using a hard board and collar and blocks, or whether it's using some kind of vacuum splint mattress. But we all need to know how to work together to minimize the risk. As for now, although the evidence is not great, maintaining a MAP of 85 to 90 does seem to provide some benefit to the patient, but maybe in the future we should be looking more at spinal cord perfusion pressure and aiming for early decompression of injury. And finally, hypothermia at the moment doesn't seem to be of clinical benefit, but there's lots of work going on in this area, and we should just keep our eyes open for potential changes.
I think Raj made a nice summary regarding early management of these cases. A couple of things I want to mention. We have done a retrospective trial on about 300 patients. It's been published, and on methylprednisolone outcomes, and we didn't see any outcome benefit on those patients in terms of long-term outcomes, as well as discharge from the rehab. And also, in the same time, we didn't see any higher complication rate. So that gives us a little bit more opportunity to maybe use methylprednisolone on healthy individuals. But I'm not going to sort of promote that at this stage. One other thing clearly beneficial is spinal cord perfusion management, and that needs to be ongoing aspect of both intraoperative and critical care management. There are ways people are exploring how can we measure that, whether we can measure the pressure in the interarticular space, or we can put some devices into the spinal cord to measure blood flow. So that may help both with mannitol administration, what type of vasopressors are beneficial for spinal cord as you elevate the blood pressure, and sort of measure the change as we would do in the TBI care. One interesting paper come up, and recently we are engaging to another study, was for elective population this time, that for lumbar spinal fusion surgeries, patient who had managed with PCAs postoperatively had more opioid consumption requirements following surgery. Again, I think analgesic management for spinal cord injured patients are becoming an interesting topic for further research. And I encourage people to start looking into the area as well.
Well, thank you, everyone. I think this was a really good discussion. It's not every day that I get to interview the president of the Trauma Anesthesia Society. Once again, this has been the Trauma Anesthesia Society's podcast. We'd like to thank our speakers, Dr. Dahl and Dr. Nathwani from Harborview Medical Center in Seattle. We also like to again thank Doc Matters for hosting our discussion. We'll be back soon with another discussion about anesthesia and the care of the traumatically injured patient.